Thanks for allowing me to speak about this. I've been wanting to do this for a while. So hopefully it is a word, transplantability. But anyway, and to talk about access to dialysis in South Africa for patients and the ethics and evidence around this. So this is a controversial, emotive, and highly costly subject, which often makes its way quietly into Parliament. So I've had lots of dealings with medical legal matters around this issue. So I'd like to just talk to you a bit about, sometimes we have to say to our colleagues, sorry, we can't dialyze, or we will dialyze, and what's it all about? Are we a secret society, or is there a bit more to it? So really what it comes down to is renal replacement therapy, be it transplant or dialysis, a big public health issue? And the fact is that it is, because number one, it's expensive, but also the prevalence is significant. So we know that chronic kidney disease affects between 5 and 10% of the population. South Africa's got some unique problems. We have some of the highest rates of HIV infection. And we also have the upper L1 risk alleles for HIV nephropathies in those patients. So in terms of our HIV population, we can expect to perhaps see more renal disease. The MRC's report in 2018 showed that our prevalence of diabetes related to obesity is over 8%. That's quite a bit. The Global Burden of Disease study in 2013, almost 40% of men and 70% of women were considered overweight or obese, and that brings its own metabolic complications. Hypertension prevalence is up to almost 30% in South African men and women. And really, there was some sort of attempt in a meta-analysis in BMC Nephrology a couple of years ago that looked at what's the prevalence of CKD 3 to 5, which is really the meat of the matter. That's where things start to matter. Might be around 4.8% of the population. So if you look at South Africa with a population around about 56 million, we're now talking about 2.7 million people with significant kidney disease. So I would say it's a fairly significant public health issue. Right, so now the next thing is then, well, is dialysis actually a worthwhile treatment? Is it worth doing it? I mean, does it have benefits? So if you look at the unit on the left, the United States Renal Data System, it looks fairly horrendous, doesn't it? I mean, so if you're 75 years of age, you have a death rate of about 350 per 1,000 population. It's better with lower age groups. If you look at a country like Spain, for example, we just moved to the right side now, their adult mortality rate or life expectancy or probability of dying between 15 and 65 years per 1,000 populations around about 60, 70. But just to look at South Africa, so our rate of death per 1,000 adults is similar to 75-year-olds in the US. So in actual fact, it's safer to be dialyzed than to actually live in South Africa. So perhaps it is a worthwhile treatment, I would suggest. So just to go into section 27 of the South African Constitution, this talks about basically healthcare and basic rights, healthcare, food, etc., etc. And what is important, the concept that's important here is that we should provide access to healthcare services. It doesn't sort of absolutely specify what degree. And what is very important in point 2 is that we are expected to achieve the progressive realization of these rights. So as our population demands increase, we're supposed to keep up, and no one may be refused emergency medical treatment. And this was the basis of the Chaskalson judgment in 1997. Actually, Professor Naicker was one of the respondents, along with the health department in Natal. And this was a gentleman who sued the state. He'd been dialyzing privately, and he sued the state because he'd run out of funds, and he said that the Constitution said he had right to healthcare. And what was interesting was that this was the judgment that is still used today, that it was decided that it is possible to limit your rights by reason of lack of resources. So given this sort of lack of resources and the demands, his case was dismissed, and this set up the sort of possibility of rationing life-saving healthcare in terms of, at least in the renal sphere. So let's just talk a little bit about resources. So if you look at where we are, if you are a public patient here over the left, notice the massive difference in prices. This is the CMS report from a year or two ago. You'll notice that a private patient has treatment rates very similar to France, Brazil, Argentina, etc. But if you are a public patient in South Africa, you're better off living in Bangladesh. Now, I'm not saying Bangladesh is bad, but the GDPs, our country, we should be doing better. And why? Well, we hosted the World Cup, which immediately I lost my discount to the International Society of Nephrology. We have to pay full rates for the Harvard courses, etc., etc. We were able to spend 8.4 billion rand on stadiums for the football, as well as $10 US. It's now established that we unfortunately bribe people to the tune of $10 million to acquire the rights to host the FIFA Cup. Minister Joe Fowler quoted the budget for financial year was a total of 64.5 billion. This, I think, is a little bit of a typo. I think it's more like maybe in the 170 billion. But what is very worrying in the South African Journal of Bioethics report on corruption, it's estimated, I mean, you know, obviously there's not great accounting when you're doing corruption. You don't keep, you know, strict books, otherwise you'd be rather silly. It's about 24 billion is deemed to be a regular expenditure for all the provinces for this 4-year period. Between April and June, we know the COVID expenditure of the government's departments exceeded 138 billion rand, and 10% is under investigation. Now, if you work out, sorry, how much it costs to dialyze a patient per annum in the state, it's estimated to be between 100 and 150,000 rand per year. With these sort of numbers, it's a little bit hard to argue that we don't have resources. You know, I'm not quite sure that that's the case, but anyway, I leave that up to you. So once again, this is the Renal Registry report from 2020. This is up to date. We in the Renal Society are actually collating this data. And not only are public patients a lot worse off than private patients, but it depends where you live. So if you happen to live in the Western Cape, you've at least got 150 million prevalence per million population of being on some form of renal replacement therapy. But heaven help you if you're in Mpumalanga or Limpopo. I mean, you've really got no chance. And once again, just to show the very different two-tier system we have in South Africa, hemodialysis predominates in private. And this is the costly part. And you think, well, sorry, you think, well, that's private. What has it got to do with me? The fact of the matter is that if people can't afford medical insurance, this puts a load on the state. So rather than adopting a more PD-friendly approach through billing mechanisms, etc., which would actually predominantly reduce the costs of dialysis in private, and therefore perhaps make it more affordable for more people to be able to enjoy dialysis, or at least attain dialysis. So in public, predominantly a PD-dominated, much more PD in public. There's quite a bit more transplant to a certain degree in the public sector versus the private sector, but this is relative to the number of patients. So the number of patients on the state transplant list, because we restrict access to dialysis, is actually not that high. It's important as well, if you look at these patient numbers and prevalence by ethnicity, you'd be sort of, if you looked at it fairly sort of superficially, you'd say, well, okay, so dialysis or renal replacement more or less reflects, not fantastically, but it reflects perhaps the population, until you ever assess the prevalence of renal replacement per million population. And you can see that the dominant population in the country is worse off. Now, that's not really fair. So the Soobramone case, so Barbara Hogan was the Minister of Health in 2009, and these were promulgated as guidelines for chronic dialysis. So they never went through the actual legislation process, which involves review and publication in the Gazette after public comment, etc. But these were kind of adopted as legislation, not necessarily entirely legally, but anyway. So basically what it was decided that you could only be dialyzed if you qualified for a transplant, and certain things made it possible that you did not qualify. So if you had an uncontrolled malignancy, perhaps reasonable, irreversible progressive disease of your vital organs, HIV, you had to be stable for a few months. Age wasn't a contraindication for chronic dialysis, interesting. If you had mental illness, if you smoked, if you're overweight, and if you were compliant. So these were some of the criteria that were applied to the state. And importantly, this document commented that unlike the public sector, transplantation should not be the major criterion for acceptance in chronic dialysis in the private sector. So we have a system in South Africa called prescribed minimum benefits for patients on medical aids, and dialysis and transplantation, renal transplantation, form part of the PMB conditions. So chronic renal disease is a PMB, but here's an example of the kind of forms that you need to fill in to look at transplant and dialysis for private patients on certain plans on medical aids. So this does not happen in isolation. So when you set guidelines in medicine, we do it with all noble intentions, but often it will be used to ration. So one of the problems is, and this will be important under a NHI type system, is will rationing be applied to patients who are privately insured as well? Those patients will then come to the state. And what I will show you in time is that the state has had zero progressive realization of renal replacement. So KDIGO is a US-based system. It issues guidelines which are adopted throughout the world. Importantly, in the US, remember that dialysis is actually guaranteed under the Constitution. You have the absolute right to be dialyzed. So their guidelines in terms of grade system are generally weak. Just to remind ourselves briefly, sort of level 1s are recommendations, which are stronger. Level 2 are suggestions, which are like, but like a recipe, and evidence, very high evidence, A, B, C, D, all the way to sort of pretty much opinion. So in the US, or in the KDIGO guidelines, the only criteria, and this is level evidence 1D, for not referring patients for transplant, in other words, what would you do, are these diseases listed here, where they have significant morbidity. So still diseases like myeloma, the plasma cell dyscrasias, amyloid, cirrhosis, severe lung disease, cardiac disease, and central neurodegenerative disease. Interestingly, they recommend only delaying transplant evaluation in patients until they are properly managed. So they will accept patients with psychiatric disorders, substance use disorder, non-adherent behavior, active infections that's not properly treated, malignancy, interestingly, even as far as Gleason scores like for prostate and less than 6, small renal tumors, cardiac disease, strokes or TIAs, peripheral vascular disease. So very, very liberal. All right, so that's some of the evidence. So this was an interesting article from Harriet Etheridge and June Fabian, who did a fair bit of work on ethics and transplant at Donald Gordon. And these are very important issues. So dialysis services had only grown by about 8%, while the population obliged to access state care has increased by 38%. Right, so 32 million to 45. So thus it appears that regressive, they called it regressive realization of the rights to access, is taking place in state sector. And this was, in their opinion, felt to be unconstitutional. There was also this issue that there's an absence of guidelines. So we have a guideline that says these people can't be transplanted, but there isn't really anything to direct practitioners in the practical aspects of rationing. So guidelines have been written for the Western Cape, but in other provinces, you kind of do whatever you want. And I'd like to show you some of these guidelines so that you can understand what our patients are up against. So Rafiq Musa, a very ethical man, very interested, the chair of the MAC, basically published or was involved in the publication of the Western Cape Guidelines in 2010. And he highlighted some of the issues which we've certainly seen. So this is in 2010, 125 new patients can be accommodated because of the number of transplants. And this is what it comes down to. So they were meeting only 12.5% of the needs of patients in the public sector. So we have been running a waiting list at Johannesburg Hospital for about 10 years. And I can tell you that we pretty much receive 200 incident ESRD patients per annum. And we currently, perhaps for our hospital, will perform less than 20 transplants because we transplant for all of Gauteng. So we are running at about 10% where we will have a slot for 10% of the patients who arrive at the hospital. So, you know, not to put, you know, life Esidimeni in a negative light, but the numbers involved in the numbers of patients who are sent home to dialysis is actually massive in relation to that scandal, massive. But it's a weird sort of, it's kept quiet, I don't know how. So it's also felt that the allocation of scarce resources must be done in a way to maximize benefit. So it was supposed to be utilitarian. Most of the recommendations are based on evidence, but yeah, we'll see. But it's also important is the experience of the clinicians working in the public sector. So you get to essentially sort of play God, I guess, but no one else will do it. So what they have is they have a 3-tier system. Category 1 patients must be accommodated. What is very nice, at least in the Western Cape, is the government is forced, if it cannot accommodate these patients, to fund private dialysis. This is not the case with us. Category 2 patients, if your resources allow, whatever that means, and category 3 patients will be offered conservative treatment. So who's what? So category 1 patients, only if you're under 50, and as you get a little bit older, you start to think, whoa, hang on a minute. Okay, your BMI needs to be less than 30. I showed you the incidence of obesity in South Africa. All right. Category 2, so if you're above 50, only if resources permit, your BMI is like that. Interestingly, hypertension with LVH, that's a bit interesting because I've yet to see a dialysis patient doesn't have LVH, smoking, diabetes, etc. And you will not be looked at if you're over 60, if you have a BMI over 35, if you're a diabetic and over 50, no. The others are pretty much in line with the Barbara Hogan document, I would submit. So it's interesting. So we restrict based on perceived outcomes. So here's an interesting statistic or for you to look at. So this is patient survival. This is from the OPTN or the SRTR. So this is how do, this is a large database throughout the US that looks at patient survival, and this is by various criteria, and this is by age. Now have a look at 65. So it's only really at 65-year-olds, you still have a 5-year survival of around 75%. I mean, there's a lot of diseases that don't. But anyway, let's say, for example, we say if you're over 60, okay, we believe that you don't do as well. And therefore, anyone over 60, fine, not for transplant. All right. Oops, well, look at this. This is a South African study. This is Dr. Sheetal Chiba's MED, supervised by Claudia de Waal, in adolescents. And look at the 1- and 5-year graft survival rates in adolescents, 51%. So the adolescent, it is now known that the adolescent period is one of the, has the worst long-term ground survival amongst pediatric age groups, as well as, frankly, above all age groups. So if we are to be evidence-based, we perhaps should not allow adolescents to be transplanted and therefore dialyzed. But I would dare anybody to try and actually publicize or legislate that. I think that would not go down well. Let's look at body mass index. Okay, here we go. Now, if you're familiar with Kaplan-Meier curves, you can see that actually amongst deceased donor kidney transplant recipients, the survival rate out to 5 years is virtually or non-significant, no matter what your BMI is. And here's an even more interesting fact. It's well known that the bigger you are, the better you do on dialysis, even if your clearances are not great. So even if your sort of dialysis efficiency is not that good, your survival is still better than small people. Interesting fact. It's a bit weird doing this because you don't get any feedback. So let's talk about HIV and ARVs. So there's very little published on this. You actually can't find a lot, but it seems based on this study that this concept of that you need to be on ARVs for 6 months and be stable allows you to sort of pretty much select out for at least 75% of patients. So it would seem to me that the criteria that we are using for HIV and ARVs is reasonable. Smoking, right. So KDIGO in its usual sense basically talks about they abstain from tobacco use a minimum of 1 month prior to waitlisting or living donor transplantation. The evidence for that is 1B. They suggest CT chest for current or former heavy smokers, more than 30 pack years per local guidelines to screen for occult lung cancer, 2C. So what does smoking actually do? All right. Fascinating, really. This was a post-hoc survival analysis of what was called the favorite trial. So post-hoc, it didn't look specifically at smoking, but current smoking was associated with a 100% increase in the hazard of, interestingly, non-cardiovascular death, 50% increase in allograft failure, and a 60% increase in the composite endpoint of death or allograft failure. So it looks like we worry very much about the cardiovascular aspects of smoking, but it looks like smokers just do very badly with transplant. And we are currently in the MAC wrestling with this idea of whether or not it's legally enforceable to not allow smokers to be transplanted. But it's tricky. All right, diabetes. Oh dear, what can you do? So in the Western Cape, this was published in the George Herald. You see, the media picks up on these things. If you're a diabetic over 50, no dialysis. All right. So we know, what is this? We know that the graft, kidney and patient graft survival rates are worse in diabetics. There's not a lot of studies looking at pure diabetes. Most of it is based on patients with pancreas kidney versus kidney alone. But 82.5% of 5 years with pancreas kidney, so it corrects it, 60% in diabetics and 88% in non-diabetic transplant patients. All right. Interestingly, and why is this? We know these are worldwide prevalence studies. So if you look at the numbers, you can see massive studies, 4 million, 3 million, et cetera, et cetera. All right. And if you look at things like in males, et cetera, the incidence or the prevalence of coronary artery disease, cardiovascular disease is up to 20 to 30%. So diabetics, this is one of the reasons that when we try and evaluate diabetics for transplantation, we bother our cardiologists a lot because we say these people have very high prevalence rates, even if they're asymptomatic. And this was an interesting study looking at what if you just do coronary angios on anybody that you want to put up for transplant? Again, one of the reasons that we do this. All right, so if you just did routine, so 39 out of these patients eventually went on to revascularization. Only one randomized control trial has actually evaluated the outcome of revascularization in ESRD patients for kidney transplant. And you see when it was published, 1992. So nobody wants to do this. Nobody's looking at this. Okay, but it's important because the difference in outcome in terms of being free of cardiovascular events, it's a small study, and I'll admit that absolutely, was highly significant if you took diabetics to transplant who had been revascularized. So if there are any of our cardiology colleagues in the audience, I know we bother you for the angios, etc., but there is some evidence for this. All right, so I'm not going to go through everything in the interest of time. It's more about the message. But we are looking at evidence to a certain degree. But what is happening is rates of transplant are dramatically different. So if you look at, this is again from Rafiq Musa 3 years ago, or 4 years ago, I suppose now, the rates of transplantation in the public sector are declining all the time. And the rates of transplant in the private sector are increasing all the time. And that is a tremendously dangerous thing for most of the South African population. So basically, those who can afford dialysis are getting more transplants, not to say anyone's to blame. And those who are not accessing dialysis are getting less transplants. So the answer here is actually transplantation. So the more we transplant, the more slots we create. And the reason that the private sector is doing better is actually not so much that they are taking more kidneys, for want of a better word, but they are doing more live kidney transplants. So they are managing to get people to come forward to donate organs to their family or their friends or anybody. And in South Africa, you can donate almost to anybody, absolutely anybody. And the one thing about the state service, it is absolutely, slots are dependent on the number of transplants that we are able to offer. Just to highlight this point, it's not all the government's fault. It really isn't. All right. Not, you know, some of it is, of course. But at any given time, there's about 4,300 South Africans on waiting lists. This is, you know, this is actually a ridiculously small number. It really is. It's embarrassing, for want of a better term. We only have, according to the Organ Donor Foundation, around 1.4 donors per million people are registered to be organ donors. This is through the, when you go to get your driver's license. There's still a lot of issues around legislation in South Africa that even though you have a driver's license, it has a sticker on it, it says, I want to be an organ donor, you are still obliged to obtain consent from the next of kin. I mean, I can see that that's perhaps a good thing or not. Okay, so in Spain, which uses an opt-out system actually, well, that's a whole different debate. The world's leading country as far as organs are concerned, 49 organ donors per million of the population. So what can we do? So just to highlight, there are two ways to look at things. These are the South African road fatality numbers over the last few years. And some people would look at it and say, this is horrendous. Look at this. These are 14,000 people who die on our roads annually, all sorts, pedestrians, passengers, cyclists, drivers, everybody. From the point of view of a nephrologist who wants to transplant people, what I can't understand is why are they not translating to organ donors? What are we doing? What can we do? What can we do better? So some important questions, well, just to say we have a lot of unnatural deaths. How do we maybe incentivize donation? Can you incentivize it? Is it okay? Do we have historical trust issues? And I want to show you what can actually happen if you get this wrong. So this was an unfortunate case. I was still a fairly junior nephrologist in those days. And you can imagine what an article like this splashed over the newspapers would do. So SA doctors charged over organ trafficking. So this happened in a couple of centers throughout the country where a group of individuals were being flown in from a well-to-do country, individuals were flown in from a not so well-to-do country, and essentially their relationship was fictitious, and around about 160 of these transplants occurred. And basically, I'm not saying this is the only reason. We've had COVID, we've had HIV, etc. In 2002, before this broke, we were doing 1,628 organ and cornea transplants. By 10 years later, a couple of years after this happened in 2010, it had halved. And the rates of organ donation are declining at a rate between 2 and 8.5% every year. And we have to get the government, the public's trust back, because it's no point talking about dialysis if you have no out, because we could just take the entire health budget for dialysis and use it. We have to have something that is cheaper and puts people back into society, and that's transplant. What we don't want is this. Okay, so in Iran, the government will buy your kidney. So it buys your kidney. And what has happened is, this is a wall outside of a hospital in Iran. And you can see kidney for sale reads one ad carrying the donor's blood type, O positive, and a mobile number with a note emphasizing urgent, insinuating that the donor is prepared to consider discounts. Competition means that some ads are actually torn down. So some people tear each other's ads down. The majority of those that end up selling kidneys in Iran are disproportionately poor. And there's no information about the long-term outcomes for sellers. So this, I would submit, is not a solution. An interesting one is funding funerals for patients who donate. One of the issues around that is, of course, is that you don't fund for people who don't donate. And I foresee problems around that. So to conclude, it's a complicated business. There's no easy answers. There is one answer that is right, staring us right in the face, and that is organ donation. So if we encourage South Africans, if we teach them, if we show them that you can give organs and you can live a normal life, you can be absolutely fine, you can save your loved ones, you can save society. We don't have to necessarily take the entire health budget for dialysis, although that would be fine with me, but apologies to my colleagues. But really there is an answer to this. Thank you very much for your attention, everybody.